Welcome to my YouTube channel.
A 14-year-old girl in Glasgow swallowed every tablet in the house after being told her hip replacement was inevitable at age 16. She survived. Others do not. Transition to adult services is another cliff edge. Pediatric teams know how to talk to children. Adult rheumatologists often do not. Medication adherence plummets. Disease flares. A boy in Manchester who had been stable for 5 years under pediatric care presented to the adult Lupus clinic with lupus nephritis class 4 and serum creatinine 400 mol/L 6 months after transfer because nobody had reminded him to take mycophenolate when he started university. Vaccination is a minefield. Live vaccines are contraindicated on immunosuppression, yet children with lupus are at higher risk of pneumococcal disease and HPV-related malignancy. The COVID-19 pandemic exposed the fragility. Children with SLE on mycophenolate and steroids had infection rates 10 times higher than healthy peers, and mortality, though rare, was concentrated in those with lung and kidney involvement. Pregnancy planning begins at menarche. Girls are counseled about teratogenic drugs before they have had their first kiss. Hydroxychloroquine is continued, mycophenolate is swapped for azathioprine, ACE inhibitors are stopped. Yet lupus pregnancies remain high risk. Preeclampsia, preterm birth, and neonatal lupus with heart block haunt the future. Research brings glimmers of hope. Neonatal Fc receptor inhibitors, CAR T-cell therapy targeting B cells, and JAK inhibitors are being trialed. In Düsseldorf, a 15-year-old girl with refractory lupus received CD19 CAR T and has been in drug-free remission for 18 months. In Toronto, another child achieved the same with daratumumab. These are single cases, but they point to a future where cyclophosphamide might become a historical footnote. Until then, every new butterfly rash on a child's face is a warning shot. In London, Paris, New York, Los Angeles, Madrid, Stockholm, Chicago, and Toronto, pediatric rheumatologists wake up every morning knowing that somewhere in their city a child is about to have her life derailed by an immune system that has declared war on its owner. She is 9 years old, or 12, or 15. She should be worrying about homework and friendships and whether her crush likes her back. Instead, she is learning the difference between lupus flare and infection, counting prednisolone tablets like other children count sweets, and praying that this month her kidneys will still work. That is pediatric systemic lupus erythematosus in Europe and America today, a disease that steals childhood in broad daylight, one organ at a time, while the world looks away because the victims are too young and too few to make headlines. But for every child living inside this war, the battlefield is the only world she knows, and the ceasefire is still nowhere in sight. Word count, 3,000. Patients that arrive in middle age, they arrive while the child is still growing. Puberty itself becomes a battlefield. In healthy girls, menarche is a milestone. In lupus, it can be a catastrophe. High disease activity and cyclophosphamide conspire to shut down ovarian function before it has properly begun. Up to 30% of girls exposed to alkylating agents will never have a spontaneous period. The psychological impact is devastating. A 14-year-old in Stockholm watching classmates buy their first bras while she is handed a prescription for hormone replacement therapy because her ovaries are already burnt out. Yet the cruelty is not evenly distributed. Ethnicity writes its own brutal footnotes. African American, Hispanic, Native American, and South Asian children suffer the worst. In the United States, black girls are 3 to 4 times more likely to develop lupus than white girls, and once they have it, their kidneys fail faster and their mortality is higher. A study from the Childhood Arthritis and Rheumatology Research Alliance, CORA, registry showed that African American children were twice as likely to have lupus nephritis at presentation and 4 times more likely to progress to end-stage renal disease within 5 years. In Europe, children of West African or South Asian descent living in London, Birmingham, or Paris mirror that grim trajectory. The reasons are only partly genetic. Poverty, late presentation, poorer access to biologics, unconscious bias in pain management, lower rates of recruitment into clinical trials, every layer of disadvantage sharpens the blade. A 15-year-old girl in the Bronx may wait months for a pediatric rheumatologist appointment while her counterpart in Copenhagen is seen within a week. By the time the American girl finally gets mycophenolate and belimumab, her kidneys are already scarred beyond repair. And then there is the brain. Neuropsychiatric lupus in children is a nightmare dressed as ordinary adolescents. Headaches that feel like an axe splitting the skull, seizures in the middle of maths class, acute confusional state that turns a bright 13-year-old into someone who cannot recognize her own mother. 20 to 40% of children with SLE will have CNS involvement, often at presentation. Stroke from antiphospholipid antibodies can leave a 10-year-old hemiplegic before she has ridden a two-wheel bike. Psychosis induced by lupus or by the steroids meant to treat it lands teenagers in psychiatric wards misdiagnosed with schizophrenia. The diagnostic delay is criminal. Average time from symptom onset to diagnosis in children is still around 12 months in many centers, sometimes longer in rural areas. A boy in rural Alabama with fever, rash, and joint swelling is treated for growing pains and juvenile idiopathic arthritis for 18 months while his kidneys quietly bleed. By the time anti-dsDNA comes back sky high and complement is unmeasurable, he is already in renal failure. When the diagnosis finally lands, the treatment is medieval in its brutality. High-dose prednisolone bloats a child's face until classmates call her Moonhead. Cyclophosphamide infusions every month for 6 months leave her vomiting so violently that she begs to die. Rituximab, belimumab, and now voclosporin have softened the edges, but access remains patchy. In 2024 a child in Romania may still receive only azathioprine and steroids because biologics are not reimbursed, while a child 600 miles away in Munich starts anakinra for macrophage activation syndrome on the same day. Macrophage activation syndrome, MAS, is the most terrifying complication of all. 10 to 15% of children with SLE will develop it, often triggered by infection or by the disease itself. Ferritin climbs into the tens of thousands, liver enzymes explode, coagulopathy turns blood to water, and the bone marrow shuts down. Without immediate high-dose steroids, anakinra, emapalumab, or even etoposide, the child dies within days. In a pediatric intensive care unit in Madrid, a 7-year-old girl arrived with ferritin 48,000, platelets 11, and triglycerides 1,200. She survived by hours. Many do not. Cardiac involvement is less common but no less lethal. Myocarditis can drop cardiac output overnight. Liebman-Sachs endocarditis throws vegetations that embolize to brain or kidney. A 16-year-old in Liverpool woke up blind in one eye because a platelet fibrin clump from a mitral valve wart lodged in her central retinal artery. She regained only partial vision. Pulmonary hemorrhage, retinal vaso-occlusive disease, intestinal perforation from vasculitis. The list of catastrophes reads like a horror story because, in childhood lupus, it is. The overall mortality has fallen dramatically since the 1960s, from over 50% 5-year mortality to under 5% in the best centers, but that statistic hides the truth: children still die. In low-resource settings the mortality remains 20 to 30%. Even in high-resource countries, a child presenting with multi-organ failure and MAS still has a 10 to 20% chance of not leaving hospital alive. Growth failure is universal if steroids are not controlled ruthlessly. A 9-year-old starting treatment at 30 kilograms may be only 135 centimeters and 38 kilograms at age 18 if glucocorticoid exposure is high. Final adult height can be reduced by 10 to 20 centimeters. Osteoporosis begins before the skeleton has finished forming. Vertebral fractures occur while riding a bicycle over a bump in the playground. The psychological toll is incalculable. Depression rates exceed 50%. Anxiety is almost universal. Post-traumatic stress disorder from repeated hospitalizations, lumbar punctures, and central lines is common. Suicide attempts are not rare. A 14-year-old girl in Glasgow swallowed every tablet in the house after